The following podcast is part of a certified educational activity titled Crafting Custom Care in CLL, Guidance on Upfront and Sequential Treatment Decisions with Targeted and Immune-Based Platforms. Access the entire activity and complete the post-test at peerview.com/WHH860. Downloadable slides and practice aids are also available.
So welcome to this session. This is, I think, the third or the fourth year in a row I've had the pleasure of chairing this meeting, and I'm very happy to do this because sorry to the industry people in the room, but I much prefer doing things for patient organizations than I do for industry at these meetings, so thank you very much for the opportunity to be here. We're going to be talking today about crafting custom care in CLL. I've got a great faculty joining us. I'll tell you already, we're going to try to get as many answers as we can when the questions come up, but we've already got dozens in, so we'll do the best that we can to try to get them into you. So I'm John Gribben from London. So we're going to start this year. Usually we've had last year we had a patient video, but this year we're going to have a nice one-on-one conversation with Brian, who, as you heard, is the co-founder and executive vice president and the chief medical officer of the CLL Society. And Brian and I have known each other a very long time.
Decades.
Yeah. Which is in itself a good reflection on how CLL has progressed over the years. So, Brian, over to you.
So, first, thank you for the opportunity to be here, and thank you to be able to present the patient's perspective on this. And I feel very lucky as a physician and a patient to have this kind of opportunity. And what I'm going to talk about is the CLL Society and what our organization tries to do to help patients, to help everyone in this room do a better job with their patients, to amplify the education and the support you're already giving those patients. Our motto is smart patients get smart care, and I think as I go through this, you'll find out how we do that. So what's a little different about us is we're laser focused on CLL. We don't do CML, ALL, anything else, just CLL. And it's patient-centric, it's patient-focused. Not that we don't have resources for physicians, but those are to help your patients. But it's also physician-curated. Everything is reviewed by one of our medical advisory boards or by myself to make sure that we're up to the minute in terms of that. And we're also a very inclusive organization that's trying to help with equitable access to the best possible care, that you shouldn't have to just go to an academic center to get the best possible care. This is a busy slide, but it gives you a sense of all the kinds of things that we do. And I'm going to highlight a couple things that Carly, who's our executive director, talked about in that video that you saw. We have 40-plus support groups, and these all meet virtually. And I would highly recommend that you consider one of these support groups for your patients. They're not just support, they're support in education groups. So we have a curriculum, and over the course of 12 months of monthly meetings, we kind of teach people from what is CLL down to what the latest research and therapy is. And these are, again, curated. We have rules of engagement. We don't give medical advice. We have the Las Vegas rule. What's said here stays here. But it's incredibly supportive when a patient meets someone like myself who's had a very aggressive form of CLL with all the bad markers, and I'm 19 years out. That's more powerful, bluntly, than anything Dr. Gribben can say to them. Because they say, oh, look, Brian looks pretty good, and it's not just me. We have dozens and dozens of these patients out there that are our ambassadors and stuff like that. We also have one-on-one help. We have a chaplaincy service. We have all kinds of educational stuff. So, take a look at this stuff, and it's there to help your patients and to help you do a more job. We're founded on 4 pillars. We started in the area of education. And when I was diagnosed in 2005, there was very little on CLL. And actually, there were not very many good treatments, and there was a pretty poor prognosis. But that's changed rapidly. And so this changing landscape is it's hard enough for clinicians to keep up with. It's hard for patients to know what's going on. We talk about the support groups. We're very involved in advocacy. I talk about small a advocacy and big A advocacy. For small a advocacy, it's teaching the patients how to get what they want out of a doctor's visit. You know, how to ask your most important question first. Don't leave it as the doctor's walking out the door. We all know that hanging door experience. By the way, that crushing retrosternal chest pain I get, you know, that's nothing, is it, doc? You know, I mean, you know how patients do that. So we ask your most important questions. Bring a care partner with you. Record the meetings, these kinds of things. We also do large A advocacies. For example, one of our big wins was changing the definition of who's immunocompromised. CLL patients were not included unless they were in active therapy, but we all know that CLL patients are immunocompromised even when they're treatment naive. That was 1.5 years of work with a number of clinicians and other people at the NIH and the CDC and the FDA to get the labels changed, to get things changed. So we do a lot of advocacy to try to improve access. And now, as Carly mentioned, we're funding research. We've always done paper research, surveys on what's important to patients, how patients make decisions that we presented at ASH and EHA and IWCLL and other meetings. But also now we're funding research. So if you're a clinician, physician scientist, you know, look at our website, you know, go to the area for researchers, and we have grant opportunities for you. We have this online toolkit which has tremendous resources for patients, and there's, you know, multiple topics on just about everything in CLL, and the patients can print these out one at a time, and I highly recommend you familiarize yourself with this, and this is a tremendous resource to help patients. We also have a medicine cabinet, and these are non-branded for the most, and these are very patient-friendly. And what they are is an explanation in patient-friendly terms of the medications, a little bit about the mechanism of action, but mostly about what are the common adverse events, how to handle them, when to call the doctor about the diarrhea or the nausea or whatnot. These are things that can be tremendously helpful. And I strongly recommend you look at that package that we put, even if you don't take it with you. Do take it with you, but even if you don't take it, open it and look through to get an idea of these kinds of things. We can mail these to you. You can print them off one at a time. A number of clinicians have used them. We get really positive feedback from the docs who use them and from the patients that they give them to. They're, I think, a tremendous resource. The website has a healthcare professional section for it, and please, you know, avail yourself of that. Everything is free, everything is downloadable, things can be mailed to you. We're there to help you make your job easier and to help patients more. So I think that's the CLL Society in a nutshell. I think you have another question for me.
I have lots of questions for you. You know, you already alluded to the fact, of course, that as a clinician you had a kind of head up on other patients, but you could yourself go back to when you were first diagnosed. Would you do, looking back, would you do anything differently? Is there anything you'd like to be able to go back and tell yourself about when you were first diagnosed and when you first needed treatment?
Well, I think what I'd really like to do differently is if I had a sense of how things are going to radically change, because things change so much that when I was diagnosed in 2005, and I was diagnosed just a month before my oldest daughter was getting married, and I had all, 17p deletion, TP53 mutated, complex hair, every kind of bad marker. It looked horrible. So
it's when you wish you hadn't been a doctor.
Right. So, yeah, absolutely. There's no advantage. I think most of us go into medical school with the belief that this is going to protect us, that we won't get sick because we're doctors and we know how to avoid it, but that doesn't work, does it? So what I would want to say to myself is kind of relax, and there's brilliant scientists working on this, and there's things happening in the lab, and there's things you're going to be able to grab hold of that are going to let you see grandchildren be born. That's what I would say to myself.
You alluded also to the fact several times now, and we're going to be talking about it today at length, is how much changes in the CLL treatment landscape have happened over that period of time. Can you talk to, you talk to lots of patients through the society. Can you talk to me about what kind of impact these sorts of treatments have had in patients' lives?
I can't overstate the importance of how this whole paradigm has shifted for patients. I mean, things are so radically different than I was diagnosed. And I see some friends around here who've had CLL even longer than I have, who've seen this kind of shift too, fellow patients. So the whole shift that's happened now is towards getting your best possible care, but knowing that still essentially all treatments are palliative, all patients are going to relapse. So it's like, I'm going to kick the can down the road, and the whole trick is to stay alive until the next treatment, and the next treatment, and the next treatment, and hope that there's some of the brilliant scientists in this room are going to find the next thing. So I think that the only hesitancy I have is it hasn't worked for everybody. We're getting to a lot of patients, but there's still too many patients that aren't getting appropriate testing before treatment. There's still too many patients that are getting chemoimmunotherapy inappropriately. That's still going on. I'm not saying that there isn't a role for that, but it's a very limited role. So that's the change has affected the people like myself, a physician, patient, but I think everybody should have access to this.
Yeah. So what do you think are the top 3 challenges or barriers that patients typically face? You mentioned one of them being, of course, getting inappropriate treatment. What do you consider the 3 challenges? Maybe I shouldn't narrow it down to 3. What are the challenges that you think that patients face?
So I think the first challenge is making sure that you're getting the most up-to-date expert care, which is very hard because things are changing so fast. In CLL, even though it's the most common blood cancer in adults in the Western Hemisphere, it's still pretty rare compared to the big 4 cancers that most hematologists, oncologists are facing. So I think getting expert care, I think, is really a critical issue for patients. The second is getting care paid for.
Yeah.
And getting access is a whole other issue too. So there can be wonderful drugs, but are they on your formulary? Is it going to be paid for? Is it you have to fail this? Are there step edits? Things like this, which are an issue. And I think the other is the support team. So for example, in my history, I've had a bone marrow transplant. I've had CAR T therapy. You cannot do that without a care partner to do that. Some of the things that I've done, the value I've gotten from other patients saying, Brian, I went through that. I got through that. That's been so valuable to me to know that stuff. So building that support team. And a lot of patients don't have that support. They're divorced, they're widowed, they're by themselves. They don't have that. So, building that, and that's one of the things that the CLL Society and other patient organizations try to do, is build a support network for people.
Sure. So, assume a patient has experienced a diagnosis of CLL. One of the advantages we've got in CLL, of course, is people have usually got a fair bit of time between their diagnosis and getting to treatment. So you're actually talking about a pretty educated group of people. Do you find that your society members are really much better informed than they used to be in general terms? Or do you find that there's still gaps in knowledge that patients as well as physicians have?
Well, there's always gaps, right? But I think people are much more informed. Now, sometimes we at the CLL Society, and that's what I ask you, is to let your patients know about us, is we feel like we're preaching to the choir. The people that are coming to us are the sophisticated patients who want to know all this stuff, and the ones that annoy you with 1,000 questions because they've read something on our website. But we want to get there to all the patients, so all patients know about this kind of stuff. So I think patients are more sophisticated now, but I think there's still areas, especially in the areas of clinical trials and stuff, that patients, there's still apprehension. And when I talk about this, there's certain underserved populations where those needs are not being met, they're not being enrolled in clinical trials, they're not accruing the way they should be, they're not representing the population.
Sure. Anything you're excited about in terms of thinking about going into 25?
Well, I'm really excited about ASH. I'm really excited about some of the new molecules that are coming. I'm really excited about the research that's going on sequencing. I'm excited about some of the new combinations that we're going to be hearing about. So, I say to patients, there's never a good time to have CLL, but there's never been a better time than today, except for tomorrow, which is going to be even better. And tomorrow is really tomorrow here at ASH, because we're going to find out new things. I just can't wait to hear some of these oral abstracts.
Sure. Great. Well, I think I could talk all day to you, but I better just get on with it. Cheers.
Thanks.
Let's see who else's introduction I can mess up now. So what we're going to be talking about today, and of course the whole issue is about talking about targeted therapies and new cellular options that are now available. The first BTK approval was in 2013. Seems longer ago than that already, doesn't it? Subsequently, there have been multiple BTK options approved, and of course the second generation and third generation BTK inhibitors, better, safer, more effective than the first. The most recent approval, of course, we've had was for CAR T therapy in 2024. And as Brian's already alluded to, this represents a huge advancement over the chemoimmunotherapy era. I can't remember the last patient I treated with chemoimmunotherapy anymore. You're saying, Brian, there's still I'm trying to think what that place might even be nowadays. I think Richter's is probably the only indication I'd have for giving chemotherapy anymore. So among the approved cellular therapies, you've seen, of course, the covalent BTK inhibitors, BCL2, the non-covalent BTK inhibitors, CAR T, and of course you're going to be hearing about lots new additions to probably each of those boxes at ASH here this year. Brian alluded to the fact, of course, we've got these choices. None of those choices are yet curative. I haven't given up in thinking that we're going to see a cure in my lifetime for this disease, and I think functionally we believe that some subsets of patients probably already are at least functionally cured. I think some of the mutated patients we could now say have been in remission for so long, remain MRD negative, we'd say that functionally they are cured, and I hope that's going to continue to improve. Also alluded to the fact, of course, that when you've been treated and when you relapse, then you have to think about what's the sequence, what's the next best treatment. When you've got choices for frontline treatment, which order should I put them in to then think about what's going to come next? The analogy I always give my patients nowadays is it's a little bit like playing a game of chess rather than playing checkers with a 4-year-old, where you're not thinking just about this move, but trying already to think 3 moves ahead in terms of planning where it is you are and where you want to be. And the plan should always be to try to keep somebody on whatever line of therapy they are for as long as possible to maintain that period of time. Here's a comparison of treatment options from this ASH presentation. You'll see at this meeting here, thinking about what's the best and worst overall outcomes you can think about in terms of what you'll see, of course, here is that we certainly agree with the concept that chemoimmunotherapy followed by chemoimmunotherapy is last year's treatment, not how we should be treating now. So what does it tell us about where we are with CLL care now? It tells us that targeted therapy is certainly the go-to first-line treatment. You're going to be hearing a lot of talks here about what's the front-line treatment you should be thinking about. We've got the options now between continuous versus time-limited options, and we have to think about when and how are things ideal for one patient versus the other. Remembering, of course, that constant important issue that patient's choice comes into this, and having a discussion with your patient about what they want and how you can deliver the best care together becomes the best way we can treat this going forward. I think I'll speak for all of the talks, including our actress over there, to say that optimal sequencing still remains unclear. It is not clear even to us what is the optimal way in which we should be thinking about how we sequence our patients. But it may become more clear when you've got a patient in front of you who's already been through that first-line treatment. You know what that treatment was. You know what the duration of response was. You've got the feel of what the disease dynamics like to make you come up together with the choice of what should be next. We do have new options after what used to be a few years ago our unmet need. Doing this session a few years ago, we were talking about the double refractory patient population being a true unmet need. But how do we think now about this? We've got new options available, and you have to think about how the treatment history, the comorbidity, patient preferences, patient's insurance and what's covered, of course, the choice of information and cellular therapies, where do they all fit? And where do these new BTK targeting strategies, including, of course, the degraders, bispecifics, and other novel monoclonal antibody therapies fit? So our goals today are to look to improve your knowledge of evidence and guidelines supporting the use of targeted immune-based therapies in treatment-naive and relapsed refractory CLL, to help you to develop more personalized upfront and sequential treatment plans, including with continuous or time-limited options, and equip you with the skills you need to develop the practical team-based strategies to ensure safe delivery of modern therapy for patients with CLL in partnership with our patients. It's a real pleasure for me now to introduce Matt Davids, a very good friend of mine from my old place at Dana-Farber, who's going to talk to you about standard targeted therapies for new time-limited combinations. Matt.
Thanks, John. Thanks so much, John. It's truly a pleasure to be here today with such esteemed colleagues. And thank you very much to PeerView for the invitation, especially to Carmine and Kelly for all their help organizing. It's also a privilege to share this symposium with Brian Kaufman, who I've also known for close to 15 years now, and I continue to learn from you, Brian, from the patient perspective, so thank you for all you do at CLL Society. So yeah, I'm going to be talking about targeted standards to new time-limited combinations. We have a lot of data to cover here, both sort of more recent data, but also some emerging data that are coming out at the ASH meeting. And one of my goals today is to highlight for you some of the key abstracts that are coming up at this meeting, where we're going to really see, I think, some practice-changing data. But of course, it's all about the patients. That's why we're all here. And so we'll start with a particular patient case. This is Michael. He's 74 and was diagnosed with CLL a few years ago, went on watch and wait. But recently, in the last few months, has become symptomatic with some B symptoms. You can see the white blood cell count has gone up to about 265. And you see the evolution of cytopenias, now with a hemoglobin less than 10 and platelets less than 100. So he now meets the IWCLL criteria for initial therapy. Test before you treat, as they say at the CLL Society. So he had the genetic marker testing, which showed an unmutated IGHV, trisomy 12, and TP53 was wild type. Remember that in addition to FISH testing, you also have to send for sequencing of TP53 to look for somatic mutations. So this is sort of an intermediate risk profile. It has some aggressive features of the unmutated IGHV, but we wouldn't consider this to be truly high-risk CLL because the TP53 is intact. So Michael has a good performance status of 1, but does have some comorbidities, hypertension, hyperlipidemia, a bit overweight. So we're going to have a little discussion to start here, just briefly, but I'm going to maybe pull Megan in first and ask you, given this presentation, is this a patient who could be considered for any modern standard of treatment? What do you think?
Yeah, so I think, looking at the prognostic testing, we have an unmutated IGHV patient. So we've said it a couple times already, but I would take chemoimmunotherapy off the table, which I'm not really using at all anymore, but just to say it out loud. And then I think certainly the two standards would be a second-generation covalent BTK inhibitor monotherapy with a treat-to-progression strategy versus, I do think, time-limited venetoclax and obinutuzumab for the CLL14 regimen I do consider in a patient like this.
And Nicole, maybe what factors would lead you to sort of recommend a continuous versus a time-limited treatment in this patient?
As John had noted earlier, you can offer either. There is some data. The unmutateds don't do as well with a time-limited approach, let's say a ven-ob in this consideration, although I think it's still a very good treatment option for this patient if he wants a time-limited approach versus continuous therapy.
How do the cardiovascular comorbidities influence you here?
If his hypertension is well controlled, I have no problems with a second-generation BTK inhibitor, so I think that is reasonable. I think if the person was a brittle cardiac patient, then you might consider a time-limited approach, although I think that with very good control and co-management, it's it's not too often that I can't tell a patient that they cannot get a BTK inhibitor nowadays, given the side effect profiles of the second generations.
Okay, great. All right, so let's talk about modern targeted standards in treatment-naive CLL. We'll review some of the evidence and where we're at with guidelines. So these are the updated NCCN guidelines in the US, and you can see on the left is frontline therapy for the non-17p deleted or TP53 mutated patients. On the right is the patients with high-risk disease, deletion 17p, or TP53 mutation. Just a few years ago, these slides might have looked very different. Often we were trying to decide between chemoimmunotherapy versus targeted therapies in that non-high-risk population. But now it has gotten a bit simpler in the sense you can see both columns look pretty similar in terms of the treatment options. You have the more selective BTK inhibitors in the case of acalabrutinib with or without obinutuzumab. We'll talk about that a little bit as to why you might or might not want to use obinutuzumab. And then you have time-limited therapy with venetoclax plus obinutuzumab. So really one of the main differences is that you have category 1 level evidence for those non-high-risk patients. On the right, you don't have that level of data because there's so few of these patients in the frontline setting, and so it's a lot smaller data sets that we're using to inform that choice. We do still have ibrutinib listed as an other recommended regimen. It can be considered here. In the US, we have a category 2A label in the NCCN guidelines for ibrutinib plus venetoclax, but we do not have an FDA label for that combination. We'll maybe talk about that in a few minutes. So ibrutinib really is the drug that revolutionized the treatment of CLL. I think it is important to respect that and pay homage to it. It's really the drug that helped us to treat patients effectively with a continuous therapy. We saw this in the US Alliance study comparing ibrutinib-based therapy to bendamustine and rituximab, where at 4 years the PFS estimate was 76% for ibrutinib arms versus only 47% with BR. And just recently, earlier this year, we saw up to 10 years of follow-up on the RESONATE-2 trial, which was the original registrational study for ibrutinib in frontline CLL, and the median PFS is about 9 years. So even though the drug does have some issues around adverse events and tolerability, for many patients it can provide very long-term benefit. However, we have the more selective covalent BTK inhibitors now, which also have accumulating longer-term data. So these are the 6-year data from ELEVATE-TN, which compared acalabrutinib with or without a 6-month obinutuzumab combination. You see the G here is for GA101, the old name for obinutuzumab, and these were compared to a control arm of obinutuzumab with chlorambucil. Both of the acalabrutinib-containing arms, as you see, were superior in terms of PFS at 72 months. And then interestingly, you do see this benefit of the acala-obin in terms of progression-free survival. It's actually about a 16% improvement in PFS compared to acala monotherapy at 6 years. So this is a common question that we get in practice. Which patients should we be considering the addition of obinutuzumab for? And you can see in the top a lot of different curves there, but it's showing that there's a benefit from a PFS perspective in both IGHV mutated and unmutated groups. However, at the bottom, these are the curves for patients with TP53 aberration. And it's probably a little hard to see, but the progression-free survival is actually nearly identical in patients who got acala-obin or acala monotherapy if they have TP53 aberrant disease. So this suggests we should not be adding obin for the patients with high-risk disease, but for patients who don't have high-risk disease, it's a consideration. Of course, it's a trade-off. We get a little bit longer PFS, but we have the inconvenience, the cost, and the toxicities of the infusion. So I think that needs to really be an individualized discussion with our patients. Now, we also have longer-term data emerging from the Sequoia study, which is zanubrutinib for frontline CLL. This previously has reported a significant PFS benefit of zanubrutinib over BR in this frontline population. And I'll highlight that at this year's ASH meeting, there's going to be 5-year follow-up, which continues to show a consistent benefit for zanubrutinib over BR. This will be a poster on Sunday evening. Median PFS has still not been reached with nearly 5 years of follow-up with zanubrutinib, and the estimated 60-month PFS rate is 76%. So it's really holding up nicely with longer-term data, similar to what we'd seen with prior data cuts. CLL14, as you know, is the study that led to the FDA approval of venetoclax plus obinutuzumab as a frontline therapy in CLL. This is a 1-year fixed duration therapy, and we've seen 6-year data just recently published, and for the first time a median PFS with ven-obin was identified at 76.2 months. And on the right, I think it's important to think about IGHV mutational status. Nicole mentioned this before, that patients with unmutated IGHV don't do as well with their initial ven-obin in terms of the durability of that first remission. You can see that's one of the second curves that drops down there, compared to patients with mutated IGHV who have these very long remissions from the 1 year of ven-obin. I do think it's important to note, though, that although these patients don't necessarily have as long of an initial remission when they have unmutated IGHV, we're still hopeful that we can actually retreat these patients, perhaps with venetoclax obinutuzumab again. And so in terms of time to next line of therapy, we're not sure yet whether those patients will actually have a shorter time to their next line of therapy. It's likely that they will have some decrement there, but I still think it highlights that ven-obin is a very effective regimen for unmutated IGHV. All right, so with those data in mind, let's go back to Michael. Same parameters here, and let's talk about treatment options. And I'm going to start with Meg again here and ask, is there a rationale for MRD-guided treatment for Michael? What do you think?
Yeah, great question. So I'll say that currently it's not standard of care to use MRD status to guide therapy, although we certainly know from data from the CLL14 study that end of treatment MRD status predicts better progression-free survival. And so we actually conducted with some other centers a study that will be presented on Monday, looking at MRD status to guide either 9, 12, or 24 months of therapy, depending on the patient's MRD status. So we'll be presenting that and its early results, but I think there could be a place for this in the future.
Yeah, I think there's quite a few studies now looking at MRD-guided therapy duration. I think yours is an important one. I'm also excited about one that's opening now in Europe that's comparing an MRD-guided strategy of pirtobrutinib and venetoclax to a fixed duration strategy of pirtobrutinib and venetoclax. And I think that's going to be interesting because it's a true head-to-head comparison of those two approaches. Now, let's talk a little bit more about BTK, BCL2 combinations. And John, I'm going to bring you in here because you probably have the most experience of ibrutinib plus venetoclax since it's approved in Europe and UK. So what about for our patient Michael here?
Yeah, so actually, since I've moved back to Europe from having been practicing here, I think it's the first drug combination I can think of that we've had access to something you don't have. I can't think of, normally we're sitting in Europe jealous of all the choices you have in the NCCN guidance. But I've treated a lot of patients with the ibrutinib-venetoclax combination in FLAIR, a very large clinical trial we did in England. But also, of course, as you already mentioned, that combination is licensed in Europe. And certainly for an unmutated patient who wants a fixed duration therapy, on the basis of that CLL14 data you showed, or the venetoclax obinutuzumab having that drop-off, that combination is my preferred option for a patient like Michael in the basis of what we're doing. The question always, of course, with venetoclax, particularly in somebody with a high white count, is the tumor lysis syndrome, and the huge advantage of coming in with a BTK inhibitor first is you debulk the patient sufficiently. And my experience of using that combination is that by the time you're given 3 months of a BTK inhibitor, it's then very easy. I think you should never underestimate the risks of tumor lysis syndrome, but it's usually very easy at that point to do the ramp up and bring in the BCL2 inhibitor. There is, of course, that issue, of course, that Michael's got hypertension, and, of course, of all the BTK inhibitors, maybe ibrutinib is the one that you're slightly concerned about, but I do agree with Nicole that my experience has been that although you have to be aware of the risks of hypertension with some of the BTK inhibitors, it's usually able to manage as long as you remember, think about it, and manage the hypertension appropriately.
And can you maybe just comment on the risk of ventricular arrhythmias with ibrutinib and if that influences your decision here?
About the risk of
ventricular arrhythmias,
yeah. Well, I have to say it's not something I've personally seen. I'm very aware of the data. I think everyone's aware of the data. When we were doing FLAIR, there was a signal came out about some episodes of ventricular tachyarrhythmias in that study. And so it's something we're aware of. I think the risk is small. I think the risk of any cardiac comorbidity is lower with other BTK inhibitors, but I don't think the risk goes away completely with any of them. So I think it's a price we have to pay for an effective drug. I've already mentioned, I mean, we're looking forward to having the second generation BTK inhibitors in combination. We don't have them yet. I know the studies have been done and we'll get them eventually. But at the moment, I'd rather use the combination for fixed duration, even though, of course, I'm aware that many of those cardiac arrhythmias occur within the first year of therapy, which is when you're doing it. But I work very closely with our cardio oncology colleagues to manage these patients. We manage them closely. If they do have any kind of arrhythmias whatsoever, we call in the cardiologist. We work very closely with them.
Great. So this is a great segue into this next segment where we'll talk in more detail about time-limited BTK BCL2 combinations. So there's a very strong scientific rationale for this approach. Ibrutinib and the other BTK inhibitors mobilize CLL cells out of their protective lymph node niches into the blood, thereby sensitizing these cells to killing with other drugs like venetoclax. And so studies like Captivate and GLOW have tested these hypotheses. Just to give you kind of a general sense for how these regimens, John kind of mentioned this already, that the regimens generally start with a BTK inhibitor monotherapy lead-in of 2 to 3 cycles. This helps to reduce the risk of tumor lysis syndrome, and then begins the combination with the venetoclax given at a standard ramp-up. And by using this approach, multiple studies have now shown a reduction in tumor lysis syndrome risk. You can see the standard dosing for the BTK inhibitors at the bottom there. When used in combination with venetoclax, we don't need to reduce the dose, so we basically are giving the BTK inhibitor at the usual full dose, and then we ramp up to venetoclax at the full dose for the duration of the combination period. So one slide to kind of summarize a lot of data from important studies of ibrutinib plus venetoclax. One of the first such studies was from the MD Anderson, where they did 24 cycles of I plus V in about 120 patients, and they've reported longer-term data now with a 5-year PFS in the range of 90% with this combination. In Captivate, there were both fixed duration and MRD-guided cohorts. Here you can see that with 12 cycles of combination therapy, fixed duration, the 5-year PFS is about 67%. And then on the right, the study John was mentioning, which is the UK FLAIR study, I plus V. This is a unique study in that the therapy duration is guided by the time it takes to achieve undetectable MRD. And so some patients had up to 6 years of therapy, and you see these outstanding PFS curves here and also OS curves, 3-year PFS of 97% with this MRD-guided approach. Captivate is going to be updated at this meeting as well, so I thought we would highlight that here. One of the interesting aspects of this is that we know that from venetoclax obinutuzumab that patients who come into that regimen with bulky lymph node disease seem to have a shorter PFS than those who don't. So they did this analysis of Captivate where they kind of did the same thing. They looked at patients who came in with 5 centimeter or greater lymph nodes compared to those who had less bulky lymph node disease. And actually with the I plus V regimen, the 5.5-year PFS was similar. So we'll see more details on that in Saturday, but I think that's an interesting analysis. So John also provided a nice segue to this next section, which is the experience of finite therapy with second-generation BTKI. We know that these different BTK inhibitors do have different spectrums of kinases that they inhibit. You can see that visually here from the kinome scan plot, where ibrutinib, although very effective at targeting BTK, also hits a number of other kinases off-target effects. And then acalabrutinib and zanubrutinib, as you can see visually, are much more selective for the BTK target with fewer off-target effects. And I'll just very briefly review some of the highlights from the head-to-head trials now that have confirmed the hypothesis that these more selective BTK inhibitors have fewer off-target side effects compared to ibrutinib. So the first of these studies to read out was Elevate-RR, which compared acalabrutinib to ibrutinib head-to-head in a relapsed refractory CLL population that was enriched for patients with high genetic risk CLL. And the median number of prior lines of therapy was 2 on this study. This was a non-inferiority design, and the median PFS was 38.4 months in both arms, so clearly showed non-inferiority of acalabrutinib versus ibrutinib. But where they saw differences were amongst these different toxicities, particularly the cardiovascular toxicities like AFib and hypertension, but also lower rates of bleeding and diarrhea and arthralgias. And you can see on the right a graph just representing one of the key secondary endpoints, AFib flutter, which was about 9% with acala versus 16% with ibrutinib. And then you see also the lower rate of hypertension with acala and lower bleeding risk. Alpine, similarly, was a head-to-head study of relapsed refractory CLL patients, comparing, in this case, zanubrutinib to ibrutinib head-to-head. This study did not enrich for high genetic risk and was a bit of a less heavily pretreated population with a median of 1 prior line of therapy. It was powered around an overall response rate endpoint, but also had a PFS as a key secondary endpoint. And unlike in Elevate-RR, here there was a PFS advantage of the second-generation BTKI, zanubrutinib, over ibrutinib. You can see it's about 11% improvement in PFS at 3 years. And there were advantages in terms of cardiovascular safety of zanubrutinib. You can see that lower AFib flutter rate of about 7% versus 17% with ibrutinib. In this study, there were no significant differences in hypertension or any grade hemorrhage between these two drugs. But overall, zanubrutinib had a very favorable safety profile, particularly when it came to more serious cardiac events. There were no ventricular arrhythmias in the zanubrutinib arm, and there were a few in the ibrutinib arm, as we've seen across the ibrutinib studies, for example. So as we think about combining these drugs together, one of the first efforts to do this was our own study of acalabrutinib, venetoclax, and obinutuzumab. This is an investigator-initiated trial that we started back in 2018. We initially recruited a population of 37 patients with all different genetic markers of CLL, and then we later amended the study to add a cohort of patients specifically with TP53 aberrant disease. We had presented some data on the early results of the study about 2 years ago now at ASH, and you can see at that time about 60% of the patients in the overall study had TP53 aberrant disease with other higher risk genetic markers as you see listed. We'd seen an 83% rate of bone marrow undetectable MRD after the 15 months of treatment in those high-risk patients, and there were very few progression events at that time. And on the right, you can just see a graphical representation of the high CR rates and high rates of undetectable MRD, both in the blood and the bone marrow. So just a quick update on this. This will be presented, I'll present this tomorrow in the poster session. This is an update now with full enrollment of our AVO study, 72 patients. And we've seen that 71% of patients with high-risk disease have achieved undetectable MRD. And you can see our 4-year PFS is in the range of 90% for all comers. And even in those patients with TP53 aberrant disease, where, for example, with ven-oben, the median PFS is about 4 years, here we're seeing in the 70s for TP53 aberrancy in terms of 4-year PFS. So the AMPLIFY study, I think, is one of the most exciting studies that I'm looking forward to seeing at this year's ASH meeting. This is the registrational trial for this AVO triplet, but also potentially an AV doublet, and these are being compared to chemoimmunotherapy in this frontline population. This study excludes patients with TP53 aberrant disease, so that is one consideration. The other thing to mention is that this is not an MRD-guided therapy duration, so both of the AV-containing arms here are about a year of combination therapy. And the primary endpoint of AMPLIFY is PFS of AV versus chemoimmunotherapy, but you can see a key secondary endpoint is the PFS of AVO versus chemoimmunotherapy. So we only know what's in the abstract published so far. We'll see the full results presented by my colleague Jennifer Brown from Dana-Farber on Monday. But what we know so far is that, at least compared to chemoimmunotherapy, both AV and AVO are advantageous in terms of the PFS outcomes. There does seem to be somewhat of an improved PFS outcome at 36 months with AVO, 83% versus 76% with AV alone. It's not a primary endpoint of the study, of course, to compare these two regimens, but it's one that we'll be very curious about as we think about which of these we want to implement in practice. Importantly, the AEs of special interest are relatively low with both of the acalabrutinib venetoclax containing regimens. You do see a little bit higher rate of neutropenia, as you might expect with AVO by adding the obinutuzumab, but low rates of tumor lysis syndrome, AFib, hypertension. So overall, these were well-tolerated regimens. Now, an important question going forward, of course, is that AMPLIFY is comparing to chemoimmunotherapy, which we've told you from the start we're not really using very much. So I think, although that study will be useful, hopefully for getting those regimens registered, I think in terms of in clinical practice, as soon as AV gets an approval, the obvious next question is, how does it compare to ven-oben? Are there particular populations that may benefit more from one or the other? And so we tried to anticipate this question now about almost 5 years ago when we started working on developing this MAGIC trial, which is comparing the AV doublet to ven-oben in the frontline population. MAGIC is now fully recruited, and so we're taking these patients and randomizing them, and in the AV arm, they can get 1 or 2 years of AV-based therapy, depending on if they achieve undetectable MRD after that first year. And also, importantly, in the ven-obinutuzumab arm, it's the same approach. So they can get 1 or 2 years of ven-oben therapy, which is a bit different from the label, of course, which is just the 1 year of ven-oben. But we really wanted to try to figure out, are there some patients who might benefit from a second year of ven-based therapy when the initial combination partner is obinutuzumab? And then also importantly, just to highlight, both treatment arms will end at 24 months, so we won't have long-term therapy on this, and eventually we'll look at PFS. So 2 different time-limited therapies, and this, I think, will hopefully be practice-informing. Now, zanubrutinib also has accumulating data in combination with venetoclax. Some of the initial data here is coming from the Sequoia study, which I mentioned before, that we talked about cohort 1, which was comparing zanubrutinib to BR. But there was a separate cohort 3, which had close to 80 patients that was just looking at zanubrutinib plus venetoclax in a high genetic risk population with TP53 aberration. And you can see the data that were presented earlier this year at EHA, where all of the patients responded. About half the patients achieved a CR with zanubrutinib plus venetoclax. We've also seen very promising triplet data with zanubrutinib, venetoclax, and obinutuzumab in a study led by Jake Sumarai at Mass General Hospital across town from us. In their original publication, they had 39 patients, and you can see the primary endpoint of undetectable MRD in the blood was met in 96% of the patients. On the right, you see these very high rates, both in the blood and the bone marrow, of undetectable MRD, so also an excellent regimen. And Jake will be updating this also at this year's ASH meeting on Saturday night in a poster with 5 years of follow-up with this bovin triplet. The triplet has also been well tolerated. We see infectious complications, as we unfortunately do with all of our regimens in CLL. They saw minor bleeding events in about half of patients, but relatively low rates of neutropenia, hypertension, and AFib flutter. All right, so let's go back to Michael now. Same scenario here. And maybe, Nicole, I'll bring you in for this first question. So is there a role for second-generation BTKI, BCL2 regimens in patients like Michael?
Well, I think John answered this very well. I think that absolutely there, for somebody who wants a time-limited approach, a second-generation combination would be very nice. And I agree with the points that John made earlier about doing so in this patient who has unmutated IgHV.
Okay. And Megan, I know you have a lot of experience with the bovine regimen because that was a collaboration with Memorial. So what about triplet therapy, especially in patients with higher risk disease? What do you think?
Yeah, so I think we still need more data. Really looking forward to seeing the AVO update since that population was enriched in the amendment for higher risk patients. And then there's going to be updated data also for the bovine triplet, which contains several patients with P53 aberrancy and high-risk features and is currently enrolling still in that patient population. So I think we need a little bit more data, but there's definitely preliminary data that looks promising there.
Yeah, I mean, I agree, and I would say for this particular patient, Michael, who's got some hypertension, hyperlipidemia, I think he's in his mid-70s, I personally would be a bit nervous with ibrutinib venetoclax to the point that John made. Some of those ventricular arrhythmias can arise within that first year, and we saw that in the GLOW study, for example. So if I were going to use that type of combination for Michael, I'd probably use either a cala-ven or zanubrutinib-ven, some of the, those types of combinations. I'm myself not convinced yet that triplet therapy is going to be better than doublet therapy. I think the Amplify study will help to begin to answer that question, at least in lower genetic risk patients. There's another important randomized study ongoing in Europe right now, the CLL 16 study, which is looking specifically at high genetic risk patients randomized to AVO versus ven-oben. I think that will be a helpful study as well. So we'll continue to accumulate data on that question. All right, and then just the last section here for me, just very briefly, is the latest on resistance mechanisms for finite therapy with targeted agents. I think one of the hopes with these combinations is that we can really reduce the risk of developing resistance mutations, for example. We know when we keep patients on very long-term BTK inhibitors, eventually they can develop mutations like BTK C481S, for example. We know with venetoclax long-term therapy, we've seen BCL2 mutations arising. So the data here are pretty sparse, but I just wanted to highlight a couple of studies. So in the CLL 14 trial, they've only reported so far on 25 patients who have progressed after their 1 year of time-limited ven-oben, but they looked for BCL2 mutations and they did not find any. So you can see smattering of different mutations that were seen. You do see more different types of mutations in the patients who had chemoimmunotherapy, particularly enrichment for TP53 aberrancy. But again, importantly, there were no acquired mutations in any of the BCL2 family genes that you see listed there. So this is, although a small amount of data, I think it's interesting and hopefully supports that there will not be BCL2 mutations arising, at least commonly, in patients progressing after time-limited ven-oben. We've also recently seen a publication on the Captivate study of BTK, in this case ibrutinib, plus venetoclax. This is from the fixed duration regimen, and they had 29 patients who had progressed after their I+V treatment had been completed. They were able to assess mutational status in 25 of these patients, and they looked in a detailed way to find any mutations in the BTK gene or PLC gamma 2, another gene commonly mutated with BTK resistance, and they did not find any such mutations. And we've seen data now suggesting that these patients can successfully be retreated with ibrutinib-based therapy, either monotherapy or additional I+V. So this does give us hope that we can use these regimens potentially multiple times, time-limited regimens for a year or a little bit longer, and then a few years later, maybe we can use the same regimen again. I would say it's probably likely that the duration of benefit will be less the second time. That's based on our prior experience with other time-limited therapies. But even if we can get a few more years of remission, I think that's valuable to be able to use these regimens multiple times. So just summarizing our first portion here, our take-home thoughts for the current therapy that we have in CLL. We've seen, and I've shown you long-term data that confirm that frontline covalent BTK inhibitors, when given continuously, are highly effective, but to do that, they do require this long-term treatment with ongoing risks, costs, and side effects. The combinations of BTK inhibitors with BCL2 inhibitor is certainly highly active. It's well tolerated for most patients, and it's allowing for these durable remissions with a time-limited approach. And I think based on Amplify, it's very likely that in the US, BTK plus BCL2 with or without obinutuzumab is likely to become a new standard of care option for our patients here in the US soon, like they've had with I+V now in Europe. And then, again, these resistance mechanisms to finite therapy with targeted agents remains an area of active investigation, but based on the data that I showed you, it does look promising so far that we'll be able to successfully retreat our patients with time-limited therapies. And with that, thank you for your attention. So I'll introduce Dr. Megan Thompson from Memorial Sloan Kettering, who's going to talk to us about the sequential treatment story in relapsed refractory CLL.
All right, thank you so much. So we're going to move into the relapsed refractory setting and start off with another case. So Sharon is an older woman with declining performance status in relapsed refractory CLL. So for her initial presentation, she had symptomatic CLL with unmutated IGHV status and actually had complex cytogenetics with a complex karyotype at diagnosis, and was initially treated with ibrutinib and had a remission, but had progressive disease after 5 years of therapy. For second-line therapy, she was treated with venetoclax in combination with rituximab based off the Murano study, so a 2-year duration of fixed-duration venetoclax, came off therapy, but is having a disease progression meeting IWCLL criteria for treatment 10 months after the end of therapy. Her comorbidities include a smoking history and comorbid COPD. She's 82 years old now with a performance status of 2. So Professor Gribben, I'll ask you, what are some impactful prognostic features of this presentation that make this patient high risk?
Well, I think you already alluded to them at the presentation. Her unmutated immunoglobulin, we've already talked about intermediate, but the complex karyotype is clearly a contributing factor to her higher risk. I think probably her highest risk feature here is that she's progressed 10 months after stopping her VENAR. You're really hoping for a longer duration of response after fixed duration therapy than this. So I'd say that as you haven't talked about what her cytogenetics are now, but I can imagine they're not good. But I think right now her major factor is she's already failed ibrutinib and now she's got a progression shortly after finishing VENAR.
Yeah, I totally agree. I think the fact that now she's had both a covalent BTK inhibitor and then short progression after time-limited venetoclax is really key here. So Dr. Davids, should testing for deletion 17p and p53 mutational status be repeated? And because you just talked about this, maybe I'll also have you speak about BTK resistance, and would you test for resistance mutations in this situation? Should you have tested earlier? Or how would you kind of approach testing now in this patient?
So, I do think it's helpful to know the 17p TP53 status. That being said, in an 82-year-old patient, I'm probably not thinking about allogeneic transplantation. So, it's not as essential, but I think
why not?
No. I think one key point to make is, 5-year remission to ibrutinib, and then did she come off due to progression or due to toxicity? If it was due to toxicity, then I do think it's important to test for BTK resistance mutations here, because if you don't find one, that opens up the possibility of using acalabrutinib or zanubrutinib. But if this patient had progressed on ibrutinib, again, I don't think it's going to change management necessarily to test for a BTK resistance mutation. So I would do it for research purposes, but not in practice.
Even if we had tested and she did have a C481S mutation after the ibrutinib, isn't it possible that the VENAR might have eradicated that clone? So do you ever consider going back to a frontline BTK inhibitor that somebody's been resistant to after VENAR? Or do you think that resistance mechanisms are so largely unknown that that's not something you would do?
I mean, there's certainly data that Ven-based therapy can decrease the size of BTK mutated clones. Eradicate to me is a bit of a strong word because I think it's probably still there. It doesn't seem likely to me that it's completely gone. So I think it wouldn't change my management there.
Sure.
Yeah, great point. So pausing a little bit to think about testing, and we heard a little bit about this in the CLL Society presentation, but it's really important for our patients to capture both their FISH status for deletion 17p, and then some other testing, including DNA sequencing for p53 mutational status. So this is a separate test just to highlight. You can have deletion of the p53 gene with deletion 17p, but it actually in the relapse setting, one of the most common scenarios is to have on the other allele a mutation in the p53 gene. And then IGHV mutational status testing, this needs to be done once during a patient's diagnosis. This does not change over time. And then doing a karyotype for the patient's cytogenetics. So just to highlight a couple of the key features we think about, we've mentioned already deletion 17p. It certainly had poor outcomes in the chemoimmunotherapy era. For patients treated with targeted agents, including covalent BTK inhibitors as well as venetoclax-based therapy, we know that these patients have improved outcomes compared to chemoimmunotherapy, but still compared to patients without p53 aberrancy with targeted agents, they do have a shorter progression-free survival. P53 mutations without a deletion 17p are an area of ongoing research, and we are going to see some updated data here at the ASH meeting. We see emerging data that really all p53 mutations are not created equally, and concurrent cytogenetic abnormalities such as a concurrent deletion 17p and complex karyotype are important there, and there's a little bit, I think, more to be learned there. And then IGHV mutational status in general, unmutated IGHV is associated with less favorable outcomes compared to mutated IGHV, and we saw some of that in the frontline data earlier with the venetoclax obinutuzumab regimen. And then complex karyotype has really emerged as an important prognostic feature. There's data, for example, with ibrutinib showing shorter progression-free survival for complex karyotype, which traditionally has been defined by 3 or more cytogenetic abnormalities, but there's also some data looking at 5 or more cytogenetic abnormalities being predictive. I'll highlight an abstract from this ASH meeting that will be on Sunday, and this is a retrospective analysis of over 1,000 CLL patients over the past decade from the Dana-Farber CLL database, and looking at patients and significant predictors of overall survival. They're in a multivariate analysis, age over 65 years, elevated beta-2 microglobulin, and p53 aberrancy were found to be significant predictors. However, in a multivariate analysis, when complex karyotype was included, the predictive value of p53 aberration was actually lost, and complex karyotype was a significant factor affecting overall survival, while isolated p53 mutation is not. And so this just highlights, I think, that we have a little bit more to learn about specific p53 mutations, as well as how other concurrent cytogenetic abnormalities modify this risk. The CLL IPI was initially validated using chemoimmunotherapy regimens in 2016, and this includes age, clinical stage, p53 aberrancy, IGHV mutational status, and beta-2 microglobulin level to provide a prognostic, predictive score for patients. There was recently an updated validation study published in Blood over the summer that showed that in the era of targeted agents, CLL IPI did maintain prognostic value in predicting PFS outcomes, but its impact in predicting survival did appear diminished with targeted agents. So we'll kind of look and need updated data as we have these new regimens to see if CLL IPI maintains its prognostic value. Just to touch briefly on the issue of resistance that comes up in the relapse setting for patients who progress during treatment with a covalent BTK inhibitor, we do know that mutations in BTK with BTK cysteine 481S mutations arise in patients at the time of clinical progression, and this particular mutation has been observed with all covalent BTK inhibitors at the time of progression. This is actually where the covalent BTK inhibitor binds BTK target. We know that these mutations functionally prevent the covalent BTK inhibitor with the BTK from engaging with the target, with the cysteine 481S mutation being a catalytically activating mutation that leads to increased B-cell receptor signaling. But when we think about BTK resistance in the clinic, I think that we already discussed this a little bit. It is not currently standard of care. I think that, it's possible it could have clinical applications in the future. You can use it to document resistance, and it may add additional information. For example, if you have a patient with rising lymphocytosis, you're not sure whether it's clinical progression at this time, infection, something else. But I really do want to emphasize that the decision to change treatment should be based on clinical progression, as we know from research that these mutations can actually arise quite a bit prior to clinical progression. So I think we have to stay tuned on the applicability of these tests for our patients still. So going back to our patient case, we did repeat FISH and next generation sequencing testing, and the patient does have P53 aberrancy with a biallelic, both del17P and a P53 mutation. So Dr. Lamanna, now that high-risk CLL is confirmed, what would you choose for this patient?
You know, strikingly, besides the high-risk features, what you brought up was the fact that the patient is 82 and frail, or becoming frailer. And so that is a big consideration regarding treatment, although we have both pirtobrutinib as approved as the first non-covalent and CAR T-cell with liso-cel being approved earlier this year are options for this patient, at least in the US, FDA approved. I would probably choose a non-covalent BTK inhibitor or a clinical trial for this older person. I'm a little bit concerned about the CAR T.
Absolutely, I agree. I think really, especially in this relapse setting, while these biologic disease features are important, the patient, always is super important with what their performance status is, comorbidities. Say this patient was a candidate for CAR T-cell therapy, Dr. Lamanna, would you consider starting pirtobrutinib as a bridge? And kind of along those lines, what are some of the logistical considerations? You mentioned performance status, but are there any others when choosing between, for example, pirtobrutinib and liso-cel?
No, absolutely. I do think, an important consideration on these patients who fail a covalent and ven-based therapy is that they're ultimately, even with the non-covalent BTK inhibitors, they're going to only last for so long. So pirto shouldn't be considered the end-all of therapy, although this lady's 82, so you never know. But for a younger patient, possibly you would need to consider alternative therapy. And so certainly using it as a bridge to CAR T is certainly an option if she's eligible for CAR T. There's no doubt that is absolutely a good indication because patients do better if you debulk them prior to CAR T. We know that patients with CAR T do better, have a longer response duration if they go into therapy with a better response.
So let's assume that this patient's younger and that liso-cel is what we're going for. The question then becomes what we mean by a bridge. And if you've already alluded, Nicole, to the fact that the pirtobrutinib duration in such a patient, presuming that the cytogenetics and the high-risk features are all still there, is not going to be terribly long. But CAR T has morbidity and mortality. Yes. How long would you kind of feel appropriate to keep her on pirtobrutinib before? I would say there's a window of opportunity here, but there's also a window to keep going with the pirtobrutinib. Yeah. So how do you kind of weigh up that balance of the benefit versus the risk of losing the window?
Absolutely. I think if somebody at this point is being already down the third line of therapy, they should be being evaluated simultaneously while they're getting their pirtobrutinib therapy. You want to plug them in because there is that fine balance of them progressing very quickly, given the median PFS on patients who are, refractory to both a covalent and ven-based therapy with pirtobrutinib. So they should be doing this simultaneously. You try to optimize response, and they can be collected and whatnot and sort of, segued into that therapy soon after. But you're right. There are some patients who have a longer response to therapy, and so you're trying to maximize. When we think, John alluded to this as trying to optimize one therapy to another therapy and sequence them for as long as possible, knowing that they may need alternative therapies, and that becomes a very, more difficult fine balance to achieve.
Yeah, outstanding points, and we'll go on to review some of that data. And then we're just going to do one more modification of the case. And so imagine this patient progressed 18 months after the end of therapy rather than 10 months after the end of therapy. So is there a role for venetoclax retreatment? Or even modifying things if we had fixed duration BTK inhibitor and venetoclax earlier, is there a role for a BTK inhibitor retreatment? Dr. Davids, any comments on this?
Yeah, so we do have some data in this setting now from the Murano study, about 25 patients who had VEN retreatment, and it tended to be patients like this who had relatively short remissions to their initial VEN-R, and the response rate is about 80% with a median PFS of 2 years. We've done a multi-center collaboration with you, kind of showing a similar thing in the real-world setting. So I think that would be a reasonable consideration. Obviously, the longer the initial remission to VEN-based therapy, the more comfortable I would be with a VEN retreatment-based strategy, but I think 18 months is a reasonable time to at least consider it.
And I think that we will save this for later, but thinking about non-covalent BTK inhibitor therapy, maybe we'll come back to this in our discussion, but could non-covalent BTK inhibitor therapy have been considered earlier, imagining it was available at that time after ibrutinib and before venetoclax? So we'll think about that as we see the rest of the presentation. So just thinking about relapse refractory CLL treatment, these are the current NCCN guidelines for CLL second line and subsequent therapy. You see a lot of options here, and I'll just emphasize that there's many sequences now that patients can go down, and so it really depends what the patient's prior therapies were, as well as the reason for discontinuation of prior therapy. So did the patient actually progress on the prior therapy and had clinical progression, or were they discontinued due to completion of planned therapy or side effects in some cases? So that leads into this concept that we've been hearing talked about, the double exposed patient versus the double refractory patient. And when thinking about this, double exposed is a patient who has relapsed CLL after exposure to both a covalent BTK inhibitor and venetoclax. So for example, patients who completed fixed duration venetoclax-based therapy for completion of planned therapy, then had a treatment-free remission, for example, of 1 to 2 years, and then need subsequent therapy, or patients who discontinued a prior covalent inhibitor for intolerance rather than progressive disease. Versus double refractory are really those patients who have progressive CLL despite treatment with both a covalent BTK inhibitor and venetoclax, or very shortly thereafter a fixed duration venetoclax regimen. And I really think that the optimal treatment-free remission after completion of fixed duration ven has not yet been clarified, and we need to see more data. I'll highlight that there is a poster abstract from Dana-Farber looking at double refractory patients and their outcomes. So we're getting more and more data on the outcomes of these patients. So what is the role of retreatment? Well, just to highlight the Murano study, now we have 7-year follow-up. So this was venetoclax for 2 years with 6 months of rituximab with a median progression-free survival of 55 months. And this is data that was alluded to from a multi-center retrospective study that looked at patients, and this did include patients retreated as well on the Murano study, and saw for ven retreatment with mostly relapsed CLL patients, including over half of patients who had prior BTK, including some patients, I should say, who had prior, it's a little under half of BTK exposure. The overall response rate was around 80% with a median progression-free survival of ven retreatment of 25 months. And we have seen data from the Captivate study looking at BTK inhibitor retreatment after fixed duration ibrutinib and venetoclax combination. So this is data that was presented by Dr. Weirda at ASCO back in the spring, and we saw 22 patients retreated with single agent ibrutinib. You'll see that the majority of patients did respond, and then there was a smaller subset of 7 patients who was retreated with ibrutinib and venetoclax in combination. So really thinking about these double exposed and double refractory patients, these are the current NCCN guidelines that have really changed over the past 12 months to now include liso-cel CAR T-cell therapy, as we discussed, as well as pirtobrutinib, with being the first non-covalent BTK inhibitor approved after a BTK inhibitor in venetoclax. And we'll talk a little bit about the data for pirtobrutinib. One of the unique features of pirtobrutinib being a non-covalent BTK inhibitor is that it binds reversibly rather than irreversibly to BTK, and it can actually overcome the resistance, including C481S mutation seen with covalent inhibitors. The Bruin study was a phase 1/2 study that looked at pirtobrutinib monotherapy in relapsed refractory CLL. This is the most recent data from patients who were treated with a prior covalent BTK inhibitor, 282 patients with an overall response rate of 82%. The median progression-free survival for all comers with prior covalent BTK inhibitor exposure was 19 months. We also saw subset data for the BCL2 inhibitor naive patients with a median PFS of 23 months versus 16 months in those double-exposed patients. And this is just to highlight that pirtobrutinib was effective across multiple subgroups, including traditionally high-risk subgroups, including complex karyotype as well as P53 aberrancy. And then we also saw responses in patients, as mentioned, with BTK C841 mutations as well as wild-type BTK. The Bruin 321 study is a phase 3 trial that tested pirtobrutinib versus investigators' choice of bendamustine rituximab or idelalisib in combination with rituximab. And we'll see the data of this study at this ASH. So these were relapsed refractory CLL patients who had prior therapy with a covalent BTK inhibitor. There were no restrictions on the number of lines of prior therapy, including venetoclax. 119 patients randomized to pirtobrutinib, 119 patients randomized to investigator's choice, the majority of which received idelalisib and rituximab. And we'll see updated data on Monday for this study. The data that we have so far is here. We do see that there was an improved progression-free survival of pirtobrutinib over investigators' choice of chemoimmunotherapy or PI3 kinase inhibitor plus rituximab, and this was seen in the subgroups listed below, including prior venetoclax, complex karyotype, and P53 aberrancy. There is also data for time-limited therapy with the non-covalent BTK inhibitor pirtobrutinib. So this is data that was recently published from a study of an arm of the Bruin study on phase 1b. Patients actually received either pirtobrutinib and venetoclax doublet in 15 patients or pirtobrutinib, venetoclax, and rituximab in 10 patients with a very high overall response rate and high rates of undetectable MRD after 12 cycles for patients on both arms, about 2/3 of patients. The combination was well tolerated, with the most common AEs being neutropenia, diarrhea, fatigue, and nausea. And this supported the Bruin CLL 322 study, which is a phase 3 study combining the triplet of pirtobrutinib, venetoclax, rituximab versus the standard of care Murano study in relapsed refractory CLL. And this is data kind of going back to the frontline setting, but since we're talking about pirtobrutinib, looking at pirtobrutinib, venetoclax, and obinutuzumab in combination, first presented by Dr. Jain at EHA, and we'll see an update on Monday at this meeting. This is a triplet regimen that has achieved very high levels of undetectable minimal residual disease at a sensitivity of 10 to the negative 6, with a rate of 89% of patients having undetectable MRD6 after 12 months of combination therapy. So liso-cel, as we've discussed, is a CD19-directed CAR T-cell therapy, the first approval of CAR T-cell therapy in patients with CLL. And this is data from the Transcend study, and we see that if you look at the graph, it's showing efficacy outcomes by patients' responses. So while the total median progression-free survival in the overall cohort was about 12 months, you can see that for patients who had CR, or CRI, which was about 18% of patients in the BTK inhibitor venetoclax failure subset, these were quite durable responses. At this ASH, we'll be seeing updated data from the Transcend study with the combination cohort, which is ibrutinib in combination with liso-cel. And this included patients with relapsed refractory CLL. And so far, what we know, and we'll see updated data again on Monday, is that there was an overall response rate of liso-cel and ibrutinib reported at 86% with a progression-free survival of 31 months. So just to talk about safety, when we're talking about non-covalent BTK inhibitors, including pirtobrutinib, monitoring is recommended for AEs of special interest that we see with all BTK inhibitors, including infections, bleeding. I do have patients, for example, hold pirtobrutinib pre and post procedure if they're getting a procedure with high risk of bleeding, monitoring for cardiac arrhythmias, secondary primary malignancies. But overall, pirtobrutinib has been very well tolerated with a low rate of discontinuation in clinical trials for adverse events. Thinking about CAR T-cell therapy, we already hit on this in some of the discussion, but there's a lot of logistical considerations with CAR T-cell therapy, so really thinking ahead and planning and referring patients to a CAR T-cell therapy center is vital. I'll highlight the toxicities of cytokine release syndrome and neurotoxicity with ICANS are certainly ones to be aware of. And then there also is the potential for earlier late onset adverse events, including cytopenias, which can be a major issue in our patients with CLL, as well as infections. So just thinking about sequential therapy, we've seen, and we saw this in our case, that CLL can undergo clonal evolution during treatment. So certain testing should be repeated prior to each line of therapy, such as FISH testing for deletion 17p and next generation sequencing for p53 mutation. The IGHV mutational status does not generally change over time. And then when we think about what a patient's therapy should be in the relapse setting, for patients who discontinued a prior regimen of, for example, venetoclax, that was the reason for discontinuation was completion of planned fixed duration therapy, there could be a potential role for retreatment before moving on to another class of agents. Pirtobrutinib monotherapy is now a standard of care option in relapse refractory CLL, and the FDA approval is after treatment with a prior BTK inhibitor and venetoclax. But we also see from data from the Bruin study that data does support its use in certain situations after a covalent BTK inhibitor and before venetoclax, and it is NCCN listed as useful in certain circumstances for this situation. And clinical trials are now investigating pirtobrutinib both in the frontline setting, for example, the PVO combination, and the relapse setting, for example, the PVR combination, as well as the data from the doublet we saw. Thinking about incorporating now non-covalent inhibitors as a fixed duration therapy. And then liso-cel has emerged as the other standard of care option in the double refractory setting. For the FDA approval is after 2 or more prior therapies, including a prior BTK inhibitor and venetoclax. And we heard from our colleagues a little bit about some of the logistical considerations that are important when we think about planning sequential therapy and planning ahead, given the time needed for collection and production. So with that, I'll thank you for your attention. I'm going to introduce Dr. Lamanna, who's going to talk about some of the newer therapies in CLL.
So I get the pleasure of sort of ending up with talking about some of newer agents that are going to be shown at this meeting and that we're all excited and many of us are participating in. So again, we're going to start with a case. So Jason, who's got relapse refractory CLL after multiple prior therapies. So he was initially diagnosed and had unmutated IGHV and a deletion 11q. He did not have a deletion of 17p. He first was treated with a time-limited approach of venetoclax and obinutuzumab, which again is 12 months, and then achieved a 18-month free remission, but then developed progressive disease and was treated with a covalent BTK inhibitor and was on treatment for 4 years, and then developed progressive disease again, and then was put on pirtobrutinib with a 1-year treatment interval, but then has developed progressive disease again. He is unable to access a CAR T slot. As mentioned earlier, sometimes You may not have the ability to obtain a CAR T for many reasons, and we can talk about that. And again, I appreciate Brian and the CLL Society for pointing out access to care is sometimes an issue for patients, depending upon whether they have an ability to be at a center that may have CAR T available, or they may be other reasons, whether it's insurance or comorbidities, that they are unable to access some of these therapies. So what are the options now for this patient? And so is there a rule for retreatment? And I know Megan had discussed this previously a little bit. Is there a rule for retreatment with venetoclax here? And so, John, I'm going to actually refer to you on this, given that he's unmutated. Is there a rule for retreatment with venetoclax here?
Well, you're kind of really very much out of options, so it's always a strategy. My preferred treatment approach here would be a clinical trial for this patient. I've always tried to have clinical trials open for this kind of patient population, but of course there may not be a clinical trial option, and I think in the absence of any clinical trial option, it's probably the only option you've kind of got really available to you here. So yes, I would consider it. I wouldn't consider it ideal, but I don't consider any situation ideal for this poor patient.
Matt, assuming that there wasn't a clinical trial option, because I know I'm covering all these new agents, but given the fact that he's had multiple therapies, what about combining some of the existing therapies? Would that be a potential option for him?
Yeah, so there are a couple of retrospective data sets now, one from Ohio State, one from the Mayo Clinic, where they took patients like this who had become refractory to either venetoclax or a covalent BTK inhibitor, and then some patients who had refractory disease to both as individual therapies, and then they combined them together as sort of an I+V style. And the majority of patients did respond, and the median PFS was in the range of about 1 year. So I've used that in a pinch a few times when I have not had a trial option, and you can get some mileage and then maybe get the patient to a clinical trial.
The only consideration there, Matt, is of course is you may get a year out of venetoclax alone. So yes,
True.
It's in this sort of patient, I think would all take a year. But in terms of looking at that data critically and saying, is it better than anything else? I agree. And again, then it comes down to, have you got the option to have that combination? Certainly in Europe, you'd only get that combination in a clinical trial setting. We would not be able to get it any other way.
Fair enough. And of course, again, that access to care is key because they may not be available to get combination strategies or newer therapies. And so you have to sort of become creative with some of these patients. What about another non-covalent BTK inhibitor or a dual newer BTK inhibitor? Megan, any consideration for that?
Yeah.
I guess John kind of alluded to all clinical trials, which lumps that in there.
Yeah, that's a great option. I think it depends. We haven't seen a ton of data yet about people progressing on pirtobrutinib and then going on to successfully get another non-covalent BTK inhibitor. But there's many new BTK targeting therapies, including inhibitors out there. So I don't know of data yet, but maybe as part of a clinical trial could be considered, if not other options. And then your next question, I think, kind of gets at that. There are these dual BTK inhibitors, newer BTK inhibitors. How those function in patients who have resistance to pirtobrutinib is not fully known from the data available yet. We have seen some preliminary data from trials of BTK degraders in patients who are this triple exposed patient population with responses in those patients. So could be an option in the future, but I think we need to stay tuned with more data.
And so this is, obviously a setup for the new agents that we're going to discuss. But certainly I think this points to the fact that because these therapies for CLL patients are allowing patients to live longer with CLL, which is a good problem to have, the fact is we're getting now multiply relapsed patients who have had covalent BTK inhibitors, ven-based strategies, and now a subset of patients that are being exposed to pirtobrutinib as the first non-covalent, and still multiply relapsed patients. So it is important to get these patients to centers that are conducting newer trials with newer agents because these patients will definitely need them. So let's talk about other non-covalent BTK inhibitors. As alluded to, pirtobrutinib is the first that is approved, but there are other non-covalent BTK inhibitors being evaluated in the space to be aware about. So nemtabrutinib is another non-covalent reversible BTK inhibitor. This was presented by Jennifer Woyak. This is the BellWave 001 study. So all these patients are relapse refractory and had to have at least 2 prior lines of therapy for their CLL, including, of course, a covalent BTK inhibitor. And you could see similar to the Bruin data that was presented earlier, if you had a C481S mutation, which is still the most common mutation to get from the covalent BTK inhibitors, the progression-free survival is going to be shorter in these individuals compared to the patients that do not have a C481S mutation. And in this study, the PFS of that cohort was approximately 16 months. So as I alluded to earlier, these patients are going to need alternative lines of therapy if they're younger. This is a good therapy strategy to have, but certainly if they're younger, they're probably going to need an alternative agent down the line, given that they have a C481S mutation and will have a shorter PFS. Now, there are some new dual activating, both covalent and non-covalent BTK inhibitors that are being evaluated in the relapse refractory space. Jennifer also presented this at ASH last year. This was LP168. It now has a name, ruxolitinib. And so initially it was evaluated in the phase 1 dose escalation study, a small cohort of about 35 patients with median 3 prior therapies, and the majority of these patients, again, having prior covalent BTK inhibitors, and a small subset already, 11% had a non-covalent BTK inhibitors, and many of them had resistant mutations. They were high-risk patients, 20 patients with deletion 17p and p53, and the overall response, at least initially presented, was 55%, with those a higher response in patients receiving a 200 milligram dose or more. Now, again, the advantage of this is that, or one of the potential advantages of these dual inhibitors is that obviously they bind covalently in the presence of wild-type BTK, but also bond non-covalently in the presence of these C481 resistant mutations. There's going to be an update of this data by Jennifer at this meeting, so at a poster session on Monday at 6 p.m., so please look forward to that data. And you can see a larger number of patients now on the study, 47 patients with relapse refractory disease, many of these having resistant mutations, and the 18-month PFS here now at 69%. And again, in patients receiving a 200 milligram dose or more, a higher overall response. So we look forward to more data with these dual active non-covalent, covalent BTK inhibitors. Now, what about a different way to target BTK, right? So we have reversible and irreversible inhibitors that we've just reviewed, sort of directly targeting BTK. But what about BTK degraders, right? So these are small molecules that induce specific degradation by ubiquitination via the cereblon E3 ligase complex and subsequent proteasomal degradation. And so there are several that are being explored on the market currently, so I'm going to go over the data that we do have. Mind you, this is early data, but we have data from 3 BGB, Nurex, and AbbVie has a compound as well. So this is some of the early data with BGB 16673 in the relapse refractory space. And again, most of these are phase 1 dose escalation studies. They're being looked at in CLL patients, but also in some of the different lymphomatous diseases as well. In the CLL space, most of these patients obviously had BTK inhibitor resistant mutations. They've received covalent BTK inhibitors. Many of them had received non-covalent and BCL2 inhibitors as well. In this early presentation that was presented at EHA earlier this year by Dr. Parando, the overall response was 72%, and again, a little higher in the patients in the 200 milligram group, 88% of the response in that patient population. There's going to be an update of this data that now it's got a Cadence 101 is the name of the study for the BGB 16673. Megan's going to present this data in an oral abstract on Monday at 3:15, so please see to that data. An increased number of patients have now been treated on study. Median prior therapies, as most of these relapse refractory studies, most of these patients have had a lot of regimens prior to them getting on these clinical trials. So median prior lines of therapy was 4, with the majority receiving covalent and BCL2 inhibitors. And you can already see 25% now having received a non-covalent BTK inhibitor. The overall response was 78%. And typically, the median time to first response on a lot of these BTK degraders is early, so here at 2.8 months. And for those patients who have been on therapy for greater than 9 months, there were 17 patients in this particular study are still having an ongoing response. So we look for more data that Megan will present on Monday. Now, what about the Nurex complex? So Nurex 5948, there's also been data presented previously last year and earlier this year at EHA with this Nurex complex, again in heavily pretreated CLL patients, showing some BTK degradation in not only the wild type and C4081S resistant mutation, but in patients who have other gatekeeper and kinase domain mutations, T474, L528W, V416. As alluded to earlier, we're still trying to figure out, what is the best way to use resistant mutation testing and how better to sequence these agents from one to another, but certainly there could potentially be a role in how we sequence depending upon patients with resistant mutations and what agent we might go to next. So here the overall response in these small cohort of patients was 69%, and there'll be an update of this by Neil Shah also on Monday as an oral abstract with now 30 patients, and the overall response was 77%. Now, AbbVie is a newer BTK degrader, and so there's not yet, the clinical trials are up and running. So this is really just the preclinical activity that I have from this compound that also looks like it has activity in relapse refractory. And they also did some preclinical work looking at this agent in combination with BCL2 inhibitor. And so certainly has activity in both wild type and patients with C481S mutation. So we look forward to more clinical data as their trials are just initiating. Now, what about other BCL2 inhibitors? Venetoclax has been the mainstay of BCL2 inhibition for many years now, and obviously really has also transformed the way we treat our patients besides the BTK inhibitors. So we have a few newer BCL2 inhibitors that are being evaluated. Sonrotoclax is an agent by BeiGene that is a potent inhibitor of BCL2 and has a shorter half-life. As we've noted, and many of my colleagues just presented, venetoclax is given as a dose ramp up, and so that can sometimes be challenging. You've already heard about when we've combined these agents with BTK inhibitors, they often front load a BTK inhibitor, so you can downgrade the patient's tumor bulk to make it easier for doing the dose ramp up of venetoclax as an outpatient, or it becomes even more challenging when you're giving venetoclax and obinutuzumab when we do that combination because of the risk of tumor lysis. So these newer generation BCL2 inhibitors are looking to see if there's a way to shorten or make it easier or less risk of tumor lysis because of their shorter half-life. So this is sonrotoclax. There's both monotherapy studies that have been run as well as combination with zanrotoclax and their covalent BTK inhibitor zanubrutinib being used in both the frontline as well as relapsed CLL patients and mantle cell lymphoma patients. And certainly they're looking at both weekly as well as daily ramp-up schedules of the sonrotoclax with zanubrutinib, and they've now chosen based on some of their data, 320 milligrams as the dose going forward of sonrotoclax. This is a report of the combination of the sonrotoclax and zanubrutinib, which was presented earlier at EHA this year, and the median follow-up of this study is now 19 months, and the overall response is very high with this combination, 97%, with over half of the patients achieving a complete response or CRI, and no significant tumor lysis or a Fib, no dose reductions due to diarrhea. There's going to be an update on the combination of sonrotoclax and zanubrutinib at this meeting as well, with an oral abstract that's going to be presented by Jake Sumarai on Monday. There's now a much larger cohort of patients on this study, 108 patients on the sonrotoclax and zanubrutinib combination with 100% overall response and high levels of undetectable MRD. So we look forward to seeing that presentation on Monday as well. Now, another BCL2 inhibitor being evaluated is lisafdiclax, with Matt Davids can tell you more about, of course. And so this is a BCL2 inhibitor with a short half-life, allowing for a daily ramp-up schedule. So you could see very quickly that you can ramp up this drug in a matter of a week. And so there's monotherapy as well as a combination study with rituximab or acalabrutinib that he's been evaluating. You don't then have to front-load the BTK inhibitor or the monoclonal antibody that we've been doing with some of the venetoclax studies that we talked about earlier, so that you can ramp up the dose in a week and then start the combination cycle 1, day 8. Here's the, some of the results from the lisafticlax plus acalabrutinib data that he's going to present at a poster presentation on Monday in the relapse refractory setting. And you can see the overall response has been very high in 87 patients that were treated at 97%, and activity seen in ven-exposed patients at 86%, and some of these patients who were ven and BTK exposed at 67%. So we look forward to more updates on his poster on Monday. So now, is Jason a candidate for a bispecific monoclonal antibody? So we talked about some of the, whether he's, can be retreated. We talked about some of these newer agents, but would you consider a trial of a bispecific monoclonal antibody? Matt, you want to comment?
Yes, I would. I was skeptical about bispecific antibodies in CLL because they rely, of course, on the immune system, which we know is impaired in patients with CLL, particularly those who've had multiple prior lines of therapy. And yet, at the IWCLL meeting, we saw some of the very early data with epcoritamab, suggesting about a third of patients in a very small cohort responded with a complete response to epcoritamab. And so it's a similar population. We're going to see some updated data, I think, that you're going to show in a second. But yes, I would definitely consider that for this patient.
Now, bispecifics are a little different than CAR T. And maybe I'll punt this to Meg since she talked a little bit about liso-cel, but do you see a difference in CRS or neurotoxicity between bispecifics and CAR T cells?
Yeah, that's a great point. I think the data is still very early on with bispecifics in CLL, so we've seen data from epcoritamab, and one of the things that has been done with this study was to modify the protocol. I think you're going to talk about that a little bit. There's no comparative data, but definitely new strategies coming about to try to modify some of the CRS and neurotoxicity.
So just to end, we're going to talk a little bit about bispecific monoclonal antibodies. And, some of them, at least in the U.S., are already approved for patients with different lymphoma subtypes, right? So we have epcoritamab is already approved for patients with relapse refractory large cell, diffuse large B cell, as well as follicular lymphoma. Mosunetuzumab is also approved for follicular lymphoma. Epcoritamab binds to CD3 on the T cells and CD20 on your B cells, obviously enhancing the T cell kill of our CLL cells. And so the very, very active early data that was presented, as Matt had alluded to earlier last year at the IWCLL meeting. And I think it took many of us by surprise about how well this data looked. Small cohort of patients, there were 21 patients initially on this study, relapse refractory CLL, but the overall response was 62%. But surprisingly, the complete responses in a relapse refractory patient population were very high at 33%. And many of these patients had TP53 aberration with complete responses of 30%, and some of them had already been double exposure. So really high responses on this initial report that made many of us have a second look. Adverse events included CRS and some cytopenias, thrombocytopenia, anemia. In general, Megan is right. It seems that obviously the data is very young, but the CRS does appear to be a little bit milder with the bispecifics than what is typically seen with CAR T, but obviously we'll need longer follow-up for both the bispecifics as well as obviously with CAR T data as that gets changed and done differently, particularly as we add other agents like covalent BTK inhibitors to that therapy. There were 3 cases of Richter's on this study, although again, remember, these were high-risk patients, and one of those patients already had disease prior to starting the study. But what are we looking at with the epcoritamab in CLL? So typically, the way this drug is being given, it's a sub-Q injection, and it's also ramped up with priming that's given sub-Q once a week. And so you go from a low dose to an intermediate dose, and then patients are typically, at least right now, being admitted for their full dose at 48 milligrams, and then they receive this once a week for cycles 1 to 3, and then every 2 weeks, cycles 4 to 9, and then once a month after that for cycles 10 on. So, because of the fact that patients need to be admitted, obviously that could be a little problematic when we talk about access of care and whether patients can do that depending upon where they are. And so Alexei Danilov will present this data as an oral abstract also on Monday, looking at an additional step-up dose at 3 milligrams for optimization. And so the goal being similar to CAR T, if we can make this more readily available to patients and mitigate the risk for CRS, that certainly then this could certainly become completely outpatient, and that would be, I think, a win-win for them. Not only for the physicians, but certainly for the patients. But certainly he's going to present data that shows that the immune-related toxicities were markedly improved with this adapted step-up schedule, and also that there was very little in the grade 1 CRS and no ICANS with this step-up dosing. So we look forward to more detail on that. Clearly, with epcoritamab, there are multiple studies going on now with combinations, and certainly the initial activity, actually, when it first got presented, was not only in CLL, but also in Richter's, which clearly is another area of unmet need in CLL patients, and certainly there are additional bispecific combinations looking at that with chemoimmunotherapy and immunomodulatory agents for patients with Richter's, so stay tuned. So when we talk about newer therapies for CLL, again, a good problem to have now that our patients are living longer with multiply relapsed disease, but certainly now we need newer therapies for these patients, and so because they're going to keep increasing for patients who have had prior covalent or non-covalent or ven-based regimens, and certainly now we have lots of new agents that are being explored, both non-covalent, other non-covalents, as well as dual covalent BTK inhibitors, BTK degraders, novel BCL2 and combinations, and now the bispecifics, and of course now we have CAR T, although that's still being certainly, hopefully will improve upon our CAR T cell therapy. There's no doubt that some of these novel agents will likely work better in combinations rather than as monotherapy, so stay tuned to some of those trials, and we have lots more work to be done, so stay tuned. I'm going to turn it over to John to finish up and to hopefully take questions.
Great, thanks, Nicole. Well, I think the original opening video and then Brian's presentation really already told you all you need to know about the excellent resources that the CLL Society has available for our patients. The CLL Society's Clinician Resource Library is just something I'm going to highlight for you here again. Here's how you can access it, and I think this does contain very, very useful information for our patients. I think we've all talked a lot about the fact that CLL patients are often very well educated about the disease. They live with the disease for a very long period of time. Brian's a great example how even high-risk patients can really have very durable responses. That gives them the opportunity to know a great deal about their disease, and I'm certainly very supportive of patients having as much very accurate information as possible to be able to help them in the decision-making process I've been talking about today. As you've been hearing from all of us, we don't often know exactly what's the right thing to do, and we're looking to see what patients want to do as part of the decision-making process that we're doing. Also, you can request these welcome kits. You can pick up some here, but you can go onto the website, have them sent to you or your practice, and certainly, again, these become very useful resources for you, your nurse practitioners, to be able to help educate our patients more. So let's get straight on and deal with the questions. Okay, I think I'm going to start with one which is, says having lost the thing, which actually, in fitting with this, came from a patient. Let's see if I can find it again. We kind of alluded to this a little bit, but I guess this came in from a patient specifically. So here's a patient who got an ibrutinib venetoclax treatment on the CLL-17 trial. He became MRD negative in peripheral blood, but not in bone marrow. So he's asymptomatic. He's now 18 months post-treatment. He's got unmutated IGH, and he's wondering what his options are. There's various questions I think I'd like to kind of allude to in here. Let me start, Megan, with you on that question of the MRD question and what you do about it. Well, of course, in Captivate, we've got an arm in the study that's kind of addressing this kind of question, not with the doublet, but with, well, it wasn't the doublet in that setting, but this whole question about when we've got a patient who comes to the end of therapy and they are MRD positive, is that an indication to continue the treatment? Not applicable right here, but let's just start with that kind of, the concept of, in other words, should we be now thinking about using MRD-directed therapy with these options that we have available to us?
Yeah, I think that's a great question. I don't have a definitive answer for you. In my clinical practice, outside of a clinical trial, I'm not using MRD status to guide therapy duration. There's been many studies that are ongoing. We talked about some of the studies. So Matt mentioned, for example, the MAGIC study is using MRD guided duration of ven-oben, so patients who are not per the protocol, MRD undetectable will get a longer duration of fixed duration therapy. We did this study that we're presenting on Monday, looking at patients who are detectable MRD at a 10 to the negative fifth sensitivity, continuing venetoclax for an additional 12 cycles of therapy. And there's other protocols out there looking at that. I don't think, though, from the data that's available, it's been definitively shown that that's helpful. And we actually know from data that patients actually can have rising MRD during continuing, for example, venetoclax-based therapy. So it's probably not as straightforward as just detectable, undetectable, and I think we'll need some of this clinical trial data to tell us.
Yeah, I think also Matt showed a beautiful slide. When you look at some of the trials, you look at Captivate, the MD Anderson data, the UK FLAIR data, for some of these that have extended their therapies, whether that be 12 cycles, 24 cycles, or more MRD guided by the UK FLAIR, there's no doubt that the PFS could increase and patients may achieve undetectable MRD, but then at some point the question is, does that become a time-limited regimen or not? So I think we do need more data, although some patients may be able to achieve an undetectable MRD, I think what we need to look at is what about the patients who don't? And some of them won't, regardless of the fact if you continue their therapy or not.
No, I think you've kind of already answered this already, but the concept of somebody being MRD positive, to my mind, is not an indication for treatment. So this patient here, I don't think any of us would be suggesting getting retreatment, and you should be waiting to see how long it takes. The interesting thing is, Matt, how long it can take patients from when you start to see a rise in MRD until you see clinical progression. That, of course, tells us something about the doubling time of these diseases. Now, we're used to seeing the progression intervals getting shorter and shorter when we were using chemotherapy, but we don't often always see that with the targeted therapies now, do we?
No, it's true, and often that provides this long window of time where you can potentially intervene, and there are trials ongoing that are looking at this. So there's intensification strategies in patients who don't achieve undetectable MRD, for example, with a BTK BCL2 doublet to add in obinutuzumab to try to further deepen response. There's studies getting underway now looking at bispecific antibodies as a consolidation strategies for patients with residual disease at the end of frontline therapy. So I think that long window that you're alluding to is a good time for patients to get on study and learn about that situation. But outside of a trial, I agree, I wouldn't do anything right now.
Sure. Slightly different but kind of related question here about a patient who's on fixed duration venetoclax, comes to the end of therapy, isn't MRD negative. Venetoclax is, of course, licensed as a continuous therapy. Do you ever consider just continuing therapy in those circumstances, or when you're doing a fixed duration approach, do you stop if you've got a response with?
For most patients,
yeah.
I do. I mean, I stop therapy. Again, similar to the conversation we had prior, I don't continue therapy. I do have that conversation with the patient to see if they want to continue a little longer and for us to do MRD testing. But we talk about the risk-benefit of doing that, and also the question is, did they want a time-limited approach to begin with? But I think we do need more data. The thing that I used, although now I don't have to do this anymore, but in the beginning, when with high-risk individuals, there were certain high-risk individual patients that sometimes I would keep on continuous therapy with venetoclax. But with some of these newer doublets or oral combinations, hopefully I'm going to be able to do that less.
But of course, the risk as we keep high-risk patients on
Correct.
venetoclax
Is that
monotherapy, those are the very
eventually-
patients we see in the BCL2 resistance mutations
Yes.
arising
Yes.
in.
Yeah,
So
sure.
I think striving for the shorter time-limited combinations is still good, even in those high-risk patients.
I'm remembering the data that came out of Melbourne from John Seymour before Murano about why they picked 2 years. That was that kind of peak, and they didn't really see much in the way of response subsequently. And I know it was a relatively small study, but there is kind of that suggestion that we probably have that fixed duration interval about right for most patients. But we're talking here about individual treatment for individual patients. Do you think we're ready for looking to start considering MRD as a treatment modality in CLL? I mean, we do it in CML, and we've done it for decades, and it can be done. And we've talked about it for as long as I can remember. looking at MRD, but is it ready for prime time? Megan, I'll come back to you because you're talking about it on Monday.
Sure. Yeah. I mean, I think one important point is that it really needs to be validated, I think, for the specific regimen and therapy. So when we're talking about MRD, certainly chemoimmunotherapy, we had a lot of data. Now we have a lot of data with venetoclax, obinutuzumab. There is some data emerging from the BTK inhibitor, BCL2 inhibitor, plus or minus anti-CD20 monoclonal antibody. But when we talk about continuous BTK inhibitors, there's actually data, for example, from the ECOG 1912 study that looked at ibrutinib rituximab versus FCR that, the MRD status for BTK inhibitor treated patients does not necessarily correlate with outcomes. So it's really important to keep in mind that it's not applicable to all patients. And so I think we're going to get into a situation where it really needs to be regimen specific. So for example, I don't see a ton of data out there right now, although there are some studies with anti-CD20 and BTK inhibitors. If you have a patient on continuous BTK inhibitor, it's important that it really hasn't been shown there. So maybe I'll stop with that, but I think it's important that we validate it for each kind of specific regimen.
And then, John, of course, the issue is the type of testing that gets done.
Yeah,
I mean, that's a whole nother conversation, right? 10 to the minus 4, 10 to the minus 6, NGS, right? So, so standardizing testing to look at minimal, you got it.
Blood. Yeah.
Standardized testing for minimal residual disease.
I don't think any of my patients are really wanting to get back. No, I don't think they want to be like AML patients getting serial bone marrows done for MRD analysis. Lost my train of thought. Oh, yeah, I remember what it was now. So the, I've already answered that one, sorry. I'll just keep going. This was targeted therapy for CLL. We kind of alluded to it several times. The big unmet need we still have is Richter's. So people asking here about Richter's. So Matt, you've got studies open for Richter's. We talked about chemotherapy being perhaps that's where we still use it, but I think any of us are going to say that we've got an answer for how this is. So you want to just talk a little bit for a couple of minutes about Richter's and where we are with that and why is it so difficult to treat?
That's a tough one. I'll start with how we treat it, which is typically with chemoimmunotherapy has been the frontline therapy for Richter's, and the outcomes, as you know, are much more poor than what we see with de novo DLBCL. That said, there is still a small proportion of patients who can achieve complete remission with chemoimmunotherapy regimens like our CHOP or our EPOC. So going back several years now, we ran studies combining venetoclax with chemoimmunotherapy, and we did see higher rates of CR and longer PFS, at least compared to historical studies of chemo alone. So that's sort of been one approach, is to try to help the chemo to work better. The other approach has been to say chemo doesn't work so well, so let's try non-chemotherapy based approaches, and there's a number of studies underway and have been reported out looking at those. One interesting aspect is the PD-1 blockade story, which you're very familiar with, which on its own is not that effective in Richter's, but there's some intriguing data with BTK inhibitors, including zanubrutinib and tislelizumab, a new combination that we've seen a promising regimen with. And then the bispecific antibody data that you mentioned earlier, I think looks really good. The BTK degraders are also being explored in Richter syndrome. So I'm optimistic that there are some good agents on the way, but right now we still don't have a great standard of care.
And CAR-T for Richter's?
Mixed experience. We published a retrospective multi-center study suggesting the response rate is fairly high, sort of 50% or so, but the CR rate is low and the progression-free survival is short.
Sure, that's been our experience too of using it, but of course, I think probably what we haven't looked at is how could we alluded to bridging to CAR-T. I think bridging to a CAR-T in Richter's makes sense to be looking. We know that the bulk of the disease is an important component in terms of the response to CAR-T, so perhaps getting the patients debulked somewhat, using some of these agents to enhance the T-cell function. We've seen the data on bringing in a BTK inhibitor to improve the outcome with liso-cel. So the same could presumably be true with Richter's. The question here about a young fit patient with T53 mutant disease, unmutated IGVH, normal karyotype, past history of ablation for atrial fibrillation. What's your... Oh, you put your head down, so that instantly brings my attention to you. I normally would think of somebody with a TP53 mutation as a candidate for BTK therapy, and I tend at the moment to use continuous therapy in that setting. Maybe that might change when I see some of the data presented on Monday, but let's see. But but history of, significant cardiac history here. What's your thinking here about treating don't worry, you're not getting off the hook. I'm going to come to all of it.
No, I mean, obviously, I still think a BTK inhibitor is important for this patient, albeit knowing that they had a prior history with, ablation. You're still going to tell them that it's a possible risk, regardless whether you use a second-generation BTK inhibitor. It still exists, although albeit much smaller than with ibrutinib. It would be nice, as John alluded to, seeing the combinations, so for oral, or triplet in somebody like this would be nice, because then you'd be getting them off of therapy potentially. So if you can give them a long response duration with high-risk disease, that would enhance my likelihood of doing an oral-oral combination in this high-risk patient because of their history. Otherwise, similarly, John, I usually do continue, if they're not on one of these trials, have been continuing chronic BTK inhibitor. Pirtobrutinib, again, not frontline, but it would be a consideration as well, given the decreased risk of AFib in this person. Although we don't have as long as follow-up, it is a very clean BTK inhibitor with regards to some of these side effects. So we'll see. But certainly, that's what I would probably do.
Dose reductions in BTK inhibitors. Thoughts?
Yeah, so I think there's been mounting data. There's a lot of data, I'll say, with ibrutinib regarding dose reductions for various toxicities, and I think we've learned a lot that can be an effective strategy. There's zanubrutinib has a lot of flexibility given the number of pills also for dose reductions.
It's harder with a CALA, isn't it?
Harder, and not to my knowledge as much data there. But that can be a strategy. I think one of the things, though, that we've seen is that there is also a lot of data. If dose reduction is not a strategy, now we have many options. So prospective data for both, for ibrutinib, for example, discontinuation for side effect, then going on to acalabrutinib, and now we've seen data from ibrutinib or acala to zanubrutinib too. So we now have these other options to switch agents within the same class.
Is age now irrelevant in the era of targeted therapy, Matt?
I wouldn't say irrelevant. It's still,
less relevant than it was.
Yeah, it's still a factor. I mean, I'm feeling more and more confident for our older CLL patients that we have the existing tools that we need to manage most of them for the rest of their lifetime with CLL treatment. I still worry more about my younger patients, where we don't know what happens decades later with these targeted therapies, and we need more options.
I think we're right out of time, aren't we? So again, thank you so much for joining us. Thank you very much to all of our patients with CLL, and thanks to the CLL Society. So thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, CLL Society. This activity is supported by independent educational grants from AstraZeneca, BeiGene, Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Lilly. To access all materials for this activity, visit peerview.com/WHH860.